All right, welcome back to the Deep Dive. Today we're going to be really diving deep into this fascinating area of circulating tumor cells. You know, we always hear about cancer and tumors and metastasis.
Yeah.
But these little cells, circulating tumor cells, CTCs, are really kind of generating a lot of excitement
Absolutely.
in cancer research right now. We've got a great research article here
Yes.
that we're going to be diving into that really talks about the clinical applications of CTC detection. And so for you, our listener, this deep dive is really going to give you a really good understanding of a cutting edge tool in cancer diagnostics.
Yeah, a really, really powerful tool.
So the goal is really to empower you with this knowledge of what CTCs are and how they are being used and how they potentially could be used
Right.
to manage and understand cancer.
Yeah.
And hopefully without getting too overwhelmed.
Exactly.
With all the technical jargon and stuff. So what we're going to do is our mission today, I guess, is to really extract the key findings about CTCs and their current role in managing breast, prostate, and colorectal cancers.
Great.
And potentially their future role as well.
Yeah.
So I guess let's just jump right in. What are these things? What are circulating tumor cells?
Yeah, so in the most basic terms, CTCs are cancer cells that have detached from either a primary tumor, so the original location of the tumor, or even from sites where the cancer has spread or metastasized.
Okay.
And they have entered into the bloodstream. And the important thing, or one of the really significant things about them is their potential to really be a marker of what we call distant metastasis.
Okay.
So that process of cancer spreading to other parts of the body.
So these are like the little seeds that are going to go and start new tumors somewhere else.
Yep.
Okay.
And it's useful to know that circulating tumor cells are actually a subtype of what we call isolated tumor cells.
Right.
Or ITCs. And so ITCs are any tumor cells that are found outside of the primary tumor or established metastatic sites.
Right.
But CTCs are just the ones that we find in the blood.
Okay. Okay. So how in the world do scientists or doctors or whoever's doing this, I imagine these things are incredibly rare, right?
Yeah.
How do they find them?
Yeah, it's definitely a challenge.
In the blood.
It's a challenge, but what we've had is that there has been a lot of progress in very sensitive molecular techniques, which has really made it possible to isolate and count these very rare cells.
Okay.
And so generally these methods involve some sort of enrichment step.
Okay.
Where you try to concentrate the potential CTCs that are in a sample.
So you're trying to concentrate the good stuff, like panning for gold or something like that.
Yeah, exactly.
Okay.
Exactly.
What are the main ways of doing that?
Yeah, so some methods are based on the physical properties of the cells.
Okay.
So things like density and size. So techniques like radiant centrifugation and filtration can help to separate cells based on these properties. And then we have some other more specific methods that rely on what we call immunomagnetic approaches.
Immunomagnetic, that sounds like it's more directly targeting these.
Exactly. So immunomagnetic separation uses what we call magnetic beads.
Okay.
So these are very tiny beads that are coated with antibodies.
Okay.
And these antibodies are specific to proteins that we find on tumor cells.
Okay.
So if these antibodies find and attach to a CTC, you can then use a magnet to pull out the labeled cell from the rest of the blood.
So it's like you're fishing for them with a magnet.
Exactly. It's like a very specific fishing method.
Okay. So the article here mentions specifically this cell search system.
Yeah.
What is it about that is significant?
Yeah, so the cell search system was developed by Veridex, and it's really significant because it has become a standardized laboratory procedure.
Okay.
And importantly, it's the only CTC detection method that has received FDA approval.
Oh, wow.
For use in the clinic.
Okay, so it's the only one that's got the
exact stamp of approval. Exactly. So it's really a validation of the reliability and the utility.
Okay, so let's walk through how this system works, the cell search system. How does it do its magic?
Yeah, so the process involves a few steps. So first, it uses those magnetic beads that we just talked about, and specifically, they're coated with antibodies against what we call EpCAM. So that stands for epithelial cell adhesion molecule.
Okay.
And EpCAM is a protein that we typically find on the surface of many epithelial cancer cells.
Okay.
So these beads are really the initial capture mechanism for the CTCs.
Okay, so they're kind of the first net
Yeah.
that catches the cells that you're looking for.
Exactly.
Okay. And what happens after they're caught in that first net?
Yeah, so then what happens is they introduce fluorescent antibodies
Okay.
to label the cells. So one type of fluorescent antibody is designed to target what we call cytokeratins,
Okay.
or CK. And so these are proteins that we find inside of epithelial cells.
Okay.
And then another type of fluorescent antibody targets CD45,
Okay.
and that's a protein that's present on white blood cells.
Okay.
And then lastly, they use a nuclear stain, which is called DAPI.
Okay.
And that allows them to see the nucleus
Okay.
of all cells.
So you've got these different colors labeling different things.
Exactly.
How do you know which of these labeled cells is an actual circulating tumor cell?
Yeah, so to be called a CTC, the cell has to have first the appearance of a tumor cell.
Okay.
So it has to look like a tumor cell.
Okay.
And then it has to stain positive for those cytokeratins. So we call that CKPE positive,
Okay.
which means that it's an epithelial cell. It also has to be positive for DIPI,
Okay.
which means it has a nucleus, so it's alive.
Okay.
And importantly, it has to be negative for CD45.
Okay.
So it's CD45 negative, meaning it's not a white blood cell.
Okay. So it has to light up for a couple things and then not light up for this
Exactly.
one thing.
Exactly.
Okay.
That way you can really distinguish those rare tumor cells from all the other cells that are in the blood.
Okay. Okay. That's pretty ingenious.
Yeah.
The article mentions that this cell search system has incredible sensitivity.
Yeah.
What does that mean?
Yeah, so the cell search system can detect as little as 1 CTC in a 7.5 milliliter sample of blood.
Okay.
And that 7.5 milliliter sample can have upwards of 40 billion blood cells.
Wow. So you're finding a needle in a haystack.
Exactly. It's really a huge technical feat to be able to do that.
Okay. Okay. So, we mentioned earlier the FDA approval in 2004.
Specifically for those 3 cancers we're talking about: metastatic breast cancer, prostate cancer, and colorectal cancer.
Yeah.
What exactly does that approval signify?
Yeah. So the approval was for predicting what we call progression-free survival. So PFS.
Okay.
And overall survival, OS, in patients with metastatic forms of these cancers.
Okay.
And so essentially what it meant was that the presence and the number of CTCs that they detected could give an indication of how long a patient might live and how long they might live without the disease getting worse.
So it's a way of predicting.
So it's a prognostic tool.
Okay. So let's start off talking about breast cancer.
Sure.
The article highlights this 2004 study by Cristofanilli and colleagues.
Yeah.
What did they find in that study?
Yeah. So this was really a landmark study in the field.
Uh-huh.
And so what Cristofanilli and his group did was they looked at patients with metastatic breast cancer, and they measured their CTC levels both before and after starting a new chemotherapy treatment.
Okay.
And what they found was really interesting, which was that patients who had 5 or more CTCs per 7.5 millimolars of blood, either before the treatment or after they started the treatment, had a shorter progression-free survival, so only 2.7 months, compared to 7 months for those with fewer than 5 CTCs.
Wow, that's a huge difference.
Yeah, it's a huge difference. And then the overall survival was similar. They found that the patients with 5 or more CTCs had a median overall survival of 10.1 months, whereas those with fewer CTCs lived for 18 months.
Okay.
So again, big difference there. And they also noted that if a patient's CTC count decreased within 4 weeks of treatment, that was associated with longer survival times, suggesting that changes in the CTC count could actually reflect how well the patient was responding to treatment.
So it's not just the initial number, is how that number changes.
Exactly.
Okay, interesting. And they found that the pre-treatment CTC count, so that number before they even started treatment, was the strongest predictor
Exactly.
of how they were going to do. Yep.
So even when they took into account other factors that can influence prognosis in metastatic breast cancer, things like hormone receptor status, they found that pre-treatment CTC count was really the most powerful independent predictor of both progression-free survival and overall survival.
Okay. So this CTC count is really a very valuable piece of information.
Yeah, absolutely.
It seems.
Yes.
The article also mentions this large retrospective study by Dawood and others that seems to support this idea.
Yeah, so they did a retrospective study, meaning they looked back at data from a large group of patients with metastatic breast cancer. And they found that about 38.4% of these patients had 5 or more CTCs, and that these patients had a significantly shorter median overall survival, only 15 months compared to 28.3 months for those with lower counts.
Okay.
And importantly, this association held true regardless of things like hormone levels, HER2 status, and even the location of the metastases.
So it really seems like the CTC count is a strong indicator across the board, basically.
Yeah.
Yeah, absolutely. A really robust indicator of prognosis.
Okay. So we've got this information from the CTCs. How does this relate to like what we see on imaging?
Yeah.
The Bud study, I guess, looked at that.
Exactly. So Bud and his colleagues directly compared CTC counts with imaging in terms of their ability to predict disease progression and survival. And they looked at patients who had been diagnosed with metastatic breast cancer based on imaging. So they categorized the patients as having either early or more advanced metastatic disease. And what they found was that in those with early metastatic disease, as detected by imaging, those with 5 or more CTCs still had a significantly shorter survival.
Okay. That makes sense if they're already showing signs of metastasis.
Yeah.
What about those who had more widespread disease but low CTC counts?
Yeah, so that's where it gets really interesting. They found that even among patients who had more advanced disease by imaging, those with low CTC counts lived significantly longer than those with high counts. So a median of 19.9 months versus only 6.4 months.
So even though the imaging was showing more disease,
yeah,
these low CTC counts were doing better.
Exactly. And so this really highlights that CTC detection can give you information that imaging alone might not.
Okay. So it's giving you some kind of insight into the biology of the disease that imaging's not giving you.
Exactly.
Okay. So the big question here for you, listener, is can we use this information to actually change how we treat breast cancer and improve those outcomes?
Right.
So, I mean, I guess the big question is, are we there yet?
Yeah, and the short answer is that we're still investigating.
Okay.
So while CTCs are a really good prognostic factor, meaning that they can predict the likely course of a disease,
Right.
We don't yet have good evidence from large clinical trials that show that making treatment decisions based on CTC results leads to better outcomes for patients.
Okay.
So we're not quite there yet.
Okay. So the article mentions the SWOG 0500 trial. What's that about?
Yeah, so this is a large ongoing study, and in this trial, women with metastatic breast cancer who have persistently high CTC counts after an initial course of chemo are randomly assigned to either continue with their current treatment or they're switched to a different treatment.
Okay.
And so the results of this trial are going to be really important in helping us determine whether or not using those CTC counts to guide treatment changes actually leads to better outcomes.
Okay. So we're waiting on that data.
Exactly.
What about the 2007 guidelines from the American Society of Clinical Oncology, ASCO?
Yeah, so those guidelines stated that CTC testing was not yet recommended for diagnosing metastatic breast cancer or for changing treatment.
Okay.
So while they recognized that it was a really good prognostic tool,
Right.
More research was needed to determine its role in guiding those treatment decisions.
Okay. Okay. So that's kind of the lay of the land for breast cancer.
Yeah.
What about prostate cancer? What do we see in prostate cancer?
Yeah, so the article discusses findings from Schaefer and colleagues in metastatic castration-resistant prostate cancer, or CRPC.
Okay.
And so these are men with prostate cancer that has progressed despite hormone therapy, and that's why we call it castration-resistant.
Right.
And what Schaefer and his team found was that over 65% of these men had 5 or more CTCs in their blood.
Okay.
And the correlation with survival was really striking. So they found that men with 5 or more CTCs had a median survival of less than a year, whereas those with fewer than 5 survived for more than 4 years.
Okay. So again, this CTC count is a very strong predictor of how they're going to do
Exactly. Yeah.
Okay. The ALMA study also looked at men with CRPC. What did they find?
Yeah, so they also saw a strong link between higher CTC counts and shorter overall survival in men with CRPC.
Okay.
And they noted that higher CTC counts were also associated with other indicators of advanced disease, such as elevated alkaline phosphatase, high PSA levels, low hemoglobin, and bone metastasis. So specifically, they found that patients with 5 or more CTCs had a median overall survival of 19.5 months, compared to more than 30 months for those with lower counts.
Okay.
So again, a big difference there.
Yeah. So these CTC counts, high counts, seem to go along with just worse disease overall.
Exactly.
Okay.
Yeah.
The De Bono study seemed to look at how treatment affected the CTC count
Exactly right.
in these men with CRPC.
Yeah, so they were really looking at the dynamic nature of CTCs and their role in monitoring response to treatment.
Right.
So they followed these CRPC patients who had high PSA levels.
Okay.
And were starting chemotherapy.
Okay.
And they looked at their CTC counts monthly.
Yeah.
And what they did was they categorized the patients as having either a favorable CTC count, which was less than 5 CTCs, or an unfavorable count, which was 5 or more.
Okay.
And as you might expect, the unfavorable group had a shorter survival. But what was really interesting is that the patients whose CTC counts improved during treatment, meaning they went from that unfavorable group to the favorable group, those patients lived longer than those whose counts remained high.
Oh, so they're actually watching these counts change over time.
Exactly. Yeah.
And seeing, okay, is this treatment actually helping, are we getting rid of these cells?
Exactly, yeah. And so that suggests that monitoring those changes in CTC counts could be a good way of seeing if the treatment's working.
Okay. The article mentions that these changes might actually be a more sensitive indicator than PSA levels, which is what we typically use, right?
Exactly, yeah. So De Bono and his colleagues found that changes in CTC counts during treatment were actually more closely linked to overall survival than changes in PSA levels at different time points.
Oh, wow.
And so this implies that CTCs might provide an earlier and more reliable indication of whether or not the treatment is working compared to that traditional PSA, which is what we've used.
Okay, so this could change how we're monitoring these patients.
Potentially, yeah.
Okay. So, the Davis study, I guess, kind of throws a little wrinkle in here.
Right.
They were looking at men undergoing radical prostatectomy.
Yeah.
So they were taking the prostate out.
Yeah.
For localized prostate cancer.
Yeah.
And they were also looking at a control group who had high PSA but negative biopsies. And what was weird was that they found CTCs in about the same percentage of both of these groups.
Exactly, yeah, about 20% of both groups.
So that's kind of weird.
Yeah, and what was interesting was that they didn't find any correlation between the CTC count and features of the tumor, like size, grade, or Gleason score.
Okay. So it seems like in the earlier stages of prostate cancer, before it spread, the CTC count may not be as helpful.
Right.
Of a tool. And the article mentions that, for CRPC, we've got PSA, so we already have a marker that we're using.
Exactly, yeah. So because PSA is already really widely used for staging prostate cancer, monitoring its progression, and detecting any recurrence after treatment, using CTCs in this context really has to show that it's giving you additional information beyond what PSA is already telling us.
Okay. And then finally, in prostate cancer, the Schercher study directly compared changes in CTC counts to changes in serum PSA levels.
Yeah.
When they were looking at patients getting first-line treatment for CRPC, what did they see there?
So what they found was that changes in CTC counts at 4, 8, and 12 weeks after treatment were significantly related to overall survival, whereas changes in PSA during that same time period didn't show a significant correlation with how long the patients lived.
So again, that's supporting the idea that these changes in CTC count are really valuable information.
Yeah, exactly.
Okay, so we've talked about breast cancer, we've talked about prostate cancer, let's move on to colorectal cancer. The article mentions this initial study by Cohen and colleagues that looked at CTC counts in colorectal cancer.
Yeah, and so their early work suggested that changes in the number of CTCs in patients with metastatic colorectal cancer during treatment might be able to give us some information about how the disease is progressing clinically.
And then they followed that up with a larger prospective study using that cell search system.
Exactly. So this was a bigger study. They had 430 patients with metastatic colorectal cancer, and they they measured their CTC counts at the start of the study, and they divided the patients into what they called a favorable group, so those with fewer than 3 CTCs, and an unfavorable group, those with 3 or more.
Okay.
And the results were really interesting. So they found that the unfavorable group, the ones with the higher CTC counts at the beginning, they had a much shorter progression-free survival.
Okay.
Only 4.5 months compared to 7.9 months for the favorable group. And their overall survival was also shorter, so 9.4 months versus 18.5 months. And they also found that patients who switched groups during the study, so they went from that unfavorable group to the favorable group during treatment, they had a longer survival than those who stayed in the unfavorable group.
So again, it's that change in the CTC count.
Exactly.
That seems to be important.
Exactly.
And so they concluded that these CTC counts were independent predictors of survival.
Yeah, that's right. They found that both the CTC count before treatment and the count during treatment were independent predictors of both progression-free survival and overall survival. And they actually looked at different subgroups of patients.
Okay.
So based on age, stage, treatment, whether or not they had liver metastasis and specific chemotherapy drugs, and the results were similar in all these subgroups.
So really a strong finding across the board.
Exactly.
Okay. And then there was this other study, the Koopman study, that I guess supported these findings as well.
Yeah, so Koopman's trial involved 467 patients who were randomly assigned to different first-line treatment regimens.
Okay.
And they found very similar results to Cohen and his group.
Okay.
So about 29% of the patients had 3 or more CTCs at the beginning of their treatment.
Yeah.
And some of them had a decrease in their counts during treatment.
Okay.
But again, they found significantly different progression-free survival and overall survival between those groups.
Okay.
And what was really interesting was that the CTC count at any time during treatment was a better predictor of both progression-free survival and overall survival than things like the location of the tumor, levels of a certain enzyme called lactate dehydrogenase, and even the treatment regimen they were on.
So it's really a strong independent predictor.
Exactly.
It seems. Okay, so we know now that in colorectal cancer, this CTC counting is providing us some good information. What about using it to guide treatment?
Yeah, so the article points out that we have this good prognostic information, but more prospective clinical trials are needed to really figure out the relationship between changes in those counts and how well different treatments work.
Okay.
However, they do point out a really interesting potential future application of this, which is identifying patients with early colorectal cancer.
Okay.
Who might be at low risk of their cancer recurring.
Okay.
And so the idea is if the CTC counts can reliably identify these patients, it might be possible to, reduce the duration of chemo, maybe stop certain drugs earlier, like oxaliplatin, which can have some nasty side effects.
Right, so you're reducing their toxicity, their exposure to these toxic chemo drugs.
Exactly, yeah.
Okay. So, as we wrap up here, what are the main conclusions about this whole CTC thing?
Yeah, so it's clear that the CellSurf system is currently the only FDA-approved method for CTC detection for use in the clinic.
Okay.
And it has a number of advantages.
Okay.
So it's semi-automated, which means there's less human error.
Okay.
There's the results are very similar between different labs.
Okay.
The results are stable even if the blood isn't processed right away.
Okay.
And it allows for real-time monitoring of patients over time.
Okay.
So it doesn't really matter if there are intermittent tumor cell release, you're getting an accurate picture over time.
Okay, so it's a good system.
Yeah, it's a good system.
And what have we learned about, its role in these different cancers?
Yeah, so we've seen that CTC detection really is a reliable prognostic indicator.
Okay.
In metastatic breast cancer, CRPC, and metastatic colorectal cancer.
Yeah.
It gives us valuable information for predicting how the disease is going to progress and how long the patients are going to live.
Okay.
And watching the changes in those counts over time could also give us some information about how well the treatment's working, and might allow us to make, faster, more informed changes to the treatment plans.
Okay. The article gives us some numbers in terms of how often we actually see these CTCs.
Right.
In these patients.
Yeah. So if you use a cutoff of 2 or more CTCs per 7.5 milliliters of blood.
Okay.
We see them in a significant proportion of patients with metastatic disease.
Okay.
So about 57% in CRPC, 37% in metastatic breast cancer, and 30% in colorectal cancer.
Okay.
But what's important is that we rarely see them in healthy people or in people with non-malignant diseases.
Okay, so that's good. It's not just,
Right.
everyone's walking around with these things.
Exactly.
Okay.
And it's worth noting that a lot of the clinical trials use a slightly higher cutoff.
Okay.
So somewhere between 3 and 5 CTCs.
Okay.
But the best cutoff is still being investigated.
Sure.
So we need more large-scale studies to really figure that out.
Okay. It seems particularly promising in certain cases, like we talked about with prostate cancer, and monitoring the treatment response.
Absolutely. So that strong correlation between changes in the counts and survival in men with CRPC compared to PSA changes really is a significant finding.
Right.
And in metastatic breast cancer, this testing seems to give us some extra diagnostic information.
Okay.
Even in cases where the imaging looks pretty similar.
Okay.
So, for example, in cases where there's, bone metastasis.
Right, which can be hard to see on imaging.
Exactly.
Okay. So it seems like you've got a lot of promise here, but we're still early.
Right.
In the game, so to speak.
Yeah, we're still early. So, we need more research to really figure out its role in all these different cancers.
Okay.
Figure out when it's appropriate to use it.
Okay.
And really establish, how important it is in all these different contexts. And another big thing is improving the sensitivity of the methods that we're currently using.
Okay.
And there are a lot of technologies that are being developed, like CTC chips, that use what we call microfluidics.
Okay.
And these could really help us to better detect these rare cells,
right,
and improve disease detection rates.
Okay. And the article mentioned something about analyzing the genes of these cells.
Yeah, so one of the really exciting things is the potential to look at the genetic material, the genes of these isolated CTCs, and that information could be really helpful in guiding personalized treatment. So
Right.
so we can tailor the therapies based on the